tends to come and go. And it can look like this, but you'll probably all notice this too. It can also look like this in the lower extremities. And what you see here is a foot that's turned in and then the toes curled. And this is a really common finding across lots of children. And this is a form of dystonic posturing or dystonia. So again, this is high muscle tone, but it's a different kind of muscle stiffness. What I can tell you anecdotally, which just means from my experience, is that spasticity seems to be getting worse from younger to older patients, whereas dystonia seems to be there constantly. But then as kids get older, the spasticity becomes so bad, you don't see the dystonia as much. But this is important because there are different types of treatments. Some of them are overlapping. So therapies, like Dr. Wishart will talk to you about, like stretching, and bracing, and promoting joint mobility can be beneficial across the board for both types. But when we talk about medications, there are some overlap, but then there are some other unique types of medications too. So for spasticity, this is probably where we have the least amount of options. And what I want to tell you about all of these medications is they can help, but none of them are perfect. Sometimes it can take combinations of medications. Sometimes it can take trial and error, trying to figure out which one works best. And it's never a complete reversal. We're not there yet. We don't know enough about it, and we don't have the right medications to do it, but we can see some mild improvements, enough to impact quality of life. And that's what we aim for when we use medications to treat high muscle tone. For spasticity, some of the medications you probably have already heard of are things like baclofen, which is a muscle relaxer, benzodiazepines like Valium, which are all just kind of relaxy in general. Alpha-2 agonists, and it's missing an A here, I apologize. These are anti-adrenaline medications like clonidine. And then finally, local treatments like Botox injections. Now, all of these things can also work for dystonia, but there are a few extra things that we start to consider if dystonia is what's causing the muscle tightness. And those can be things like Sinemet, which is also used in treating Parkinson's disease and the stiffness in Parkinson's disease, gabapentin, trihexyphenidyl, and tetrabenazine. Now you're going to get this list of medications, both in our care packet and also in the slides that I'm going to share with you. When you go to your neurologist or your physical medicine and rehabilitation doctor, the important thing is to let them know that it's appreciated that both spasticity and dystonia are contributing towards muscle tightness in kids with ML4. It'll be up to your provider to assess your child and sort of see what is more prominent and what's causing more of an issue in your child specifically. And from there, they'll be guided to these medications. They'll already know them. These are standard medications, not specific to ML4. So definitely talking to your neurologist or your PMNR doctor are probably the most important things you can do for the high muscle tone. Okay, going on from muscle tone, since we're talking about it, another thing that's popped up recently are muscles affected in ML4? And this is a really interesting topic here. When I first started seeing kids with ML4, because muscle tightness was such an issue, I didn't really think about muscles being involved primarily, because in order for a muscle to be stiff, that muscle has to be strong, or at least relatively strong. It still has to be working because that muscle needs to contract to make the stiffness. Now, there was data in the ML4 mice that had been reported years ago saying that there was a type of involvement in the muscle called a muscular dystrophy. And what muscular dystrophy means is that muscle fibers, which you see pictured here, this is a cross section or a cut through muscles. And each one of these little circles is a cross section of a muscle fiber. What they had indicated in the mice was those muscle fibers were having a hard time hanging on to the connective tissue around them. Connective tissue around them is like a support structure. And if you can't hang on to that support structure, muscle fibers become injured. And that's the type of injury they were seeing. Now, if you hear the term muscular dystrophy, one of the things that might pop up in your head, those kids look different from kids with ML4. In muscular dystrophy, those kids, they're very limp and sort of like loose. They don't have high muscle tone, they have low muscle tone because their muscles aren't contracting. They have very pronounced atrophy of their muscles, more so than kids with ML4. And the muscle biopsy, they progress very fast. And that's not clinically what we were seeing with ML4. So over time, we started hearing reports about CK levels being elevated. And what are CK levels? So CK is creatine kinase. What you see here is a staining of the muscle fibers where CK is stained in brown. And you can see there's tons of brown everywhere. And that's because muscle fibers express high levels of this enzyme, which is really important. And this is, you don't have to know the details of this. It's important in energy metabolism. So it works with your mitochondria and it works with glycolysis to supply energy to the muscles. And if the muscles are sick and break down, because they have so much of this creatine kinase in them, it gets released into the blood. And we can measure that. And blood levels of creatine kinase, if they're very high, are indicative of muscle breakdown. And that's illustrated here. So when we started hearing that CK levels were really high in some of our patients, it made us start thinking, well, maybe there is muscle involvement in patients as well as in mice. I don't know the details because this is an area of new investigation, but I want to bring up a few things. So one, we don't really have muscle biopsies from very many patients at all. We have a report of at least 2 muscle biopsies so far, and they did show some evidence of muscular dystrophy or some involvement. But we've also had EMGs or electromyograms that have been performed on older patients, which did not show evidence of a muscular dystrophy or primary muscular involvement. So I think it's going to be a mixed picture. And what's really important is, does it impact these kids and should we care? Because the muscle atrophy that we see in the vast majority of patients looks like disuse atrophy. Atrophy means getting smaller, by the way, or shrinking of the muscles. So if you don't use your muscles because maybe they're very stiff or you can't move them volitionally because you're weak, they will shrink. But the shrinkage or the type of atrophy that we saw is more with disuse, not with a primary muscle involvement. So I think that there may be some primary muscle involvement, but I don't think it explains the weakness or the symptoms very much because, again, muscle tone tends to be high and not low in a lot of our kids. So I'm uncertain if primary muscle issues are significantly affecting strength, to be honest, or function in kids. But I do think it's important that we keep it in mind because muscle breakdown, which can happen if there's this muscular dystrophy, especially at times when kids are sick, can release something called myoglobin, which is the red pigment in muscles, into the blood, and that can cause injury to the kidneys. And if you know already that there's primary muscle involvement in your child, you will know to be hyper aware during times of bad illness that CK levels should be monitored or at least looked at least once. Because if they are elevated, it means that myoglobin is probably also elevated in the blood, and aggressive rehydration is the appropriate treatment to help protect the kidneys. So in essence, we should care, not because I think it's going to be a huge part of what we look for in treatment efficacy, but rather I think it's going to be important because if muscles are getting broken down later in life or at times of extreme illness, it's going to be important to know that so that we can protect the kidneys. Well, how do you know if your child has muscle involvement or not? Because again, I think this is going to be heterogeneous. Not everyone is going to have the same degree of muscle impairment. Maybe it doesn't come out at the same time of life. And so every patient has to be approached individually. So one thing to do is just to test CK levels. And if you come see me at MGH, CK levels will be sent in every patient that I see just to get a baseline. Another is an electromyogram or an EMG. And that's when there's a little needle that's taken and placed in the muscle. And I've had this done to myself, and it's a little bit discomfort. There's a little bit of discomfort, but it's not painful. And it actually looks at muscle activity. And that muscle activity can tell you whether or not there is muscle involvement. If there is evidence of muscle involvement, I would recommend going forward with a muscle biopsy, taking a very small piece of muscle, and we're talking tiny, and this is a minimally invasive procedure, and actually having the pathologist look at it to see if there's muscle involvement. Because if there is, we know you should be hyper aware during times of very bad illness about CK levels. So again, a very evolving picture here. We're trying to learn and collect data and learn more on it, but we're in the very early stages of understanding muscle involvement in ML4. Something that's more readily appreciated have been these episodes of chronic eye pain. And what we've been discussing is, these eye pain issues, they tend to occur earlier in life and then go away. They tend to come and go and be very brief, but very painful and very profound. And they tend to be somewhat infrequent, like not happening every day, but maybe once a week or once a month. Now, that varies from patient to patient, and I don't want to make too big of a generalization here. But we don't really understand where the eye pain episodes are coming from, and there are two different thoughts. One is that it could be from corneal injury. This is the picture of an eye. It's very hard to see the iris because the eye has been dilating. That's the colored part of your eye. This whole big dark space is actually the pupil because medication has been put into this eye to make the iris expand. And this line of light is highlighting the cornea. And that's the clear coating or the clear hard part over your eye, the tissue. And there's a thought that maybe the cornea in ML4, because it is cloudy, is also maybe weaker and more susceptible to injury. And injury to the cornea is really painful. And you could potentially, this could be a source of the corneal eye pain. And so what we're recommending, and again, these slides will be available to you, this is what is normally recommended across the board for anyone who has corneal abrasions. So when considering treatment for eye pain episodes, you should see an ophthalmologist. And these are the recommendations they're going to give you. And it's going to be for preservative-free eye drops, 1 to 2 in each eye, about 6 times per day. It's a lot. It requires frequent treatment. And a preservative-free lubricating gel or ointment that's instilled 1 time before bed that protects the eye overnight. It's really important that it's only preservative-free drops and preservative-free lubricants because you're using them so frequently. The preservatives can actually hurt the eye if there are preservatives in it. And your ophthalmologist can help you get and identify what preservative-free eye drops and lubricants there are available. Alternatively, we've been discussing whether or not these could be headaches. And that came up because it's not always obvious that these pain episodes are precipitated by touching the eye or injury to the eye or poking to the eye. There are types of headaches. I know this sounds really weird because we all have an idea of what headaches are in our head, but there are types of headaches that can look sort of like this. They come by different names: paroxysmal hemicrania, SUNA, and SUNC. But basically, these sorts of headaches tend to be very brief, maybe seconds to minutes in duration, very intense. They come with watering or tearing of the eye, sometimes flushing of the face and sweating, and they come and go. And they respond to medications differently from other kinds of migraines. So talk to your neurologist if you're having these as well, because there are treatment options that include endomethacin, lamictal, carbamazepine, and gabapentin. Again, these are known treatments for these types of headaches. So if you're having these and they're not responding to the eye drop treatment from your ophthalmologist, the second line is to talk to your neurologist and discuss whether they think one of these diagnoses may be appropriate, and they may want to pursue one of these treatment options. Okay, another sort of frequent problem in ML4, iron deficiency anemia, and we've been talking a lot lately about reflux. And to understand this more, I want to talk about sort of the involvement of the stomach in ML4. And some of you maybe already know this very well, is that stomach acid levels in kids with ML4 are very, very low. If you look at this picture of the stomach here, there are 2 types of cells I want to point out. This little guy right here called a parietal cell, and another little guy here called the G cell. And so what happens in you and I is that parietal cells are responsible for making stomach acid. And when the stomach acid is in the stomach, it's detected by G cells. So G cells are like detectors, or like almost a thermostat for pH or acid in the stomach. If there's not enough acid in the stomach, these G cells make a signal called gastrin. And you've probably heard about this in the context of ML4. Gastrin is responsible for going back to parietal cells and saying, hey, make more acid. And then they do. Well, in ML4, the actual mutation in TRPML1 or M:1 is responsible for dysfunction in parietal cells, and it stops them from being able to make stomach acid. when these G cells see that there's not enough acid, they're continually sending out this signal gastrin saying, hey, make more acid, make more acid. And when it never happens, they just keep making more and more gastrin. So we see really high levels of gastrin in kids with ML4. And this can be one of the markers that help actually diagnose the disease. But what it means for patients is that they have a chronic situation where there's not enough acid in the stomach. And this is called achlorhydria. Symptoms of achlorhydria include epigastric pain, weight loss because you're not absorbing or digesting things like proteins well enough if you don't have stomach acid, reflux, bloating, and poor iron absorption. So the reflux in this case and in kids with ML4, this isn't reflux like you and I are experiencing or common reflux, which is acid coming up into our esophagus. Rather, it's probably bile from down here in the upper part of the intestine, that yellow kind of stuff that, maybe if you've seen vomit, sometimes it's bile, it's that yellow stuff. It's not acidic, it's actually basic. It's the total opposite. And that can cause a lot of discomfort in reflux, but it's treated much differently, right? Because normally you and I would think to take an antacid, but in kids with ML4, there is no acid production. So that's not gonna help anything. In fact, it may even make things worse. We're not really sure, we don't know. But there are alternatives to treatment, which I'll go over in 1 second. The other is to know that acid, or the pH of the stomach and the food, is really important in your ability to absorb iron. And iron in food is not absorbed well in kids with ML4. Now, the iron supplementations that kids are given are different from the iron that's in food, and they are absorbed better. We're trying to understand whether or not those iron supplementations are actually effective in helping anemia in kids with ML4, because we get questions all the time. Well, how anemic is too anemic? Is this oral supplementation working? Should we do IV supplementation? Is that helpful or dangerous? And we don't know, and we're trying to find out. That's part of what we're doing with the retrospective study. And actually, Stephen has been dedicated to sort of pulling that data out and trying to analyze it. So hopefully I'll have more insight for you soon. But what I can say is that I do think the oral iron supplementation is absolutely appropriate, and it should be absorbed better than the iron that's in food. What about the bloating and the reflux? Again, like we talked about, it's not likely to be acid since kids with ML4 can't make acid. It's probably these basic bile salts. Antacids won't work. So what can you do? Well, honestly, it's not very well understood in the setting of achlorhydria. Achlorhydria can happen in other disorders, but if you look into the literature, there are not a lot of recommendations on what may or may not work. And there definitely aren't clinical trials that I could find. I think that if reflux is an issue, you should probably talk to a gastroenterologist. So even more so than talk to your pediatrician first, of course. But I think going to a specialist is more appropriate because this is a very special case of reflux. This is not standard reflux. Things that can be done. Well, maybe the most extreme sort of version of this is a fundoplication, or actually minor surgeries, and we do this quite commonly. And it basically is depicted here, where part of the stomach is wrapped around the esophagus to prevent fluid from coming up into the esophagus. But there are medications too that may work in the setting of achlorhydria. One is sucralfate, which coats the stomach and prevents it from being injured, and cholestyramine, which is a medication that's also used to lower cholesterol in the blood, but it also lowers the amount of bile salts. And bile salts is what's probably being refluxed in these kids and may have an impact. Now again, reflux in the setting of achlorhydria should probably be managed by a gastrointestinal specialist. And I'm not gonna, so whatever their professional opinion is appropriate, and you should follow their guidance. But these are just examples of things that may work. All right, sticking on the stomach issue too, food intake is very, very important, food and hydration, especially when we're thinking about now that maybe muscles are involved and maybe muscle breakdown happens if you're not eating or drinking enough. And we know that kids with ML4, because chewing is really slow, it can be really hard to get enough nutrition in, and it's so important. So just a word about G-tubes and oral intake, because this has come up a lot. So G-tubes are just an alternative method of being able to get nutrition into the stomach. It's this small little button, here are two that are depicted, and it basically goes right through the abdominal wall and into the stomach. It's a very minor surgery, and it's completely reversible. What it would allow, though, is sufficient nutrition or hydration when you can't achieve that orally. And that can be really important. But things I want you to know is having a G-tube does not mean you can't eat. The G-tube is just a backup mechanism. So you can eat and drink all you want as long as you'll be able to swallow safely. The G-tube in some cases is just at the end of the day, if you haven't eaten or drank enough, this allows you a mechanism of ensuring proper nutrition and hydration, which can be so important. So keep an open mind about G-tubes in general, talking to your pediatrician at any point where they think nutrition intake isn't adequate, because I do think that this is really, really important. All right. Sleep issues. This is something else that's come up. And this is really interesting. We don't have a great grasp on this. We're actually part of our prospective study that we're launching involves a little mini study on sleep issues in ML4 so we can better understand them. But when I think about sleep issues in ML4, one, I can tell you that kids normally have issues with sleep, period. But in the case of ML4, there's two other patient populations that come to mind. One are patients that have visual loss. So generically, this is sort of describing your circadian rhythm. And what you should know is that your brain knows when to wake up and when to go to sleep based on daylight. Daylight helps entrain that. And if you're losing vision, you're not getting that signal from the sun to help entrain that circadian rhythm. And that can become very, very altered. It's really interesting. There were some really kind of extreme experiments done back in the 70s. A lot of them in France, I believe, and other parts of Europe, where they were trying to understand circadian rhythm. And people would voluntarily put themselves into seclusion in these underground chambers with no light, so that no light could affect your circadian rhythm. And they learned very, very valuable information, which is that intrinsically, if you don't have light, your circadian rhythm can vary anywhere from like 20 to 40 hours, meaning that your natural rhythm, waking up and sleeping, if you're not getting sunlight, is definitely not 24 hours. And that can lead to real big sleep disturbances. So that may be one factor playing into sleep issues in ML4, this disorder called non-24, circadian rhythm being impaired when you're losing vision. The other is that we see sleep issues pop up in other neurodevelopmental disorders as well. And one of the things that I was hearing was that some kids are having these episodes of giddiness or laughter before bedtime, where they're becoming sort of hyperactive and laughing. That's actually seen in another disorder called Rett's syndrome. Rett's syndrome looks very different, and it's much, much more severe. But it has been reported twice that there are these episodes of inappropriate laughter or giddiness prior to bed. We don't know what causes them, and there are no treatments associated in that literature with being able to treat them. But it does clue us in to know that this may also be a feature of the disorder itself, as well as with the non-24. So what things can you do for these kids? Well, one is that your body temperature actually has to drop a few degrees before you can fall to sleep at night. A hot bath or a hot shower before bed can help with that. What that does is it dilates all the blood vessels in your arms and your legs. And when your blood vessels are dilated, blood is flowing through them and giving off heat. And that leads to a drop in body temperature. You can help that by keeping room temperature around 65 degrees, a little harder to do in the summer. But around that temperature, your body will drop its body temperature appropriately to be able to fall asleep. Now that also means making sure that you don't put on like 4 comforters or 4 blankets like in response to it being colder, because that'll just defeat the whole purpose. Melatonin can also be very helpful. This is something that you can get over the counter. It is a natural hormone that's produced by your brain in response to sunlight going away. And it helps entrain your brain to know it's about time to go to sleep. And you can talk to your pediatrician or your neurologist. Doses, depending on age and weight, range anywhere from 3 to 10 milligrams. And they're usually taken about 3 hours before bed to help set up your brain to know that it's time to fall asleep. Now, with non-24 in patients with visual impairment, sometimes that can be so bad that melatonin's not enough. But Ramelteon is another medication that's prescription only, that works like melatonin and on melatonin receptors, but is like 10 to 20 times stronger than melatonin. This has shown some efficacy in non-24 and may also help kids with ML4. We haven't been able to try it yet, and I don't know anyone who has, so I'm very, very interested. If any of you see a sleep specialist or a neurologist or a pediatrician who prescribes it, I would love to know if it's effective. So these are suggestions. There are other sedatives that can help you go to sleep, but across the board, all other sedatives basically help you fall asleep, but they usually almost always impair your quality of sleep, whereas melatonin and Rameltian shouldn't. So those are the two I put there. Okay, and a final thing here, a final thought. Now let's move to kidney failure in ML4. So this has been something that we have a very poor understanding of as well. But it seems that, and not all patients again, but some patients in their 20s and 30s have experienced kidney failure. We believe it's a direct result of ML4 itself. This is a picture of a kidney here, and this is a zoomed in version of sort of like, this is a functional unit in your kidney called a glomerulus, and this is where your blood gets filtered. And from the very, very sparse data that we have from biopsies or tissue samples from patients is that there's a pattern of injury called focal segmental glomerular sclerosis that can evolve later in life. And that's going to be meaningless to you. It just means patchy damage. And we don't know what's causing it. We think, again, it's actually due to the ML4 mutation itself. We do have a nephrologist who's a renal doctor who started to work with us, Dr. Sharma, and we're really hopeful to get more insight on what's going on here. But we think that the consequence of this later in life is basically all of these things that are related to kidney failure. And this can be rapidly progressive and something that you have to keep an eye on. Unfortunately, there are no known interventions, so we don't really know what to do about it yet, except for monitoring blood pressure, making sure that fluid intake is appropriate, and being under the guidance of a renal doctor is extremely important if there is evidence of this going on, because it needs to be monitored. Okay. So I wish I could go over everything, but I mean, I'm already at an hour here. What I'd like to tell you is that we still have so much more work to do. So moving forward, like what kind of other stuff do we have to do? There's so much, and this will be an ongoing conversation with us and you guys. I'm really hopeful to see you guys in the spring of 2021, where we're going to be putting on the ML4 conference in person again. But what I'd like to do is follow up this talk with a packet that I can, through Rebecca, we can put out together. So this packet, again, on ML4 associated symptoms and possible treatment options that you can share with your providers. I'd love to send you guys a description of the new prospective natural history study so that you, like a flyer about what's in the works, accompanying instructions on how to enroll, and contact us so that you can get enrolled and participate in the natural history. Instructions on setting up a visit to be seen here at MGH so that I can see you guys as my patients. If I see you guys in research, meaning like at the conference only or at your home only or anything like that, that's a research visit, and I'm not officially your physician. So for stupid legal reasons, I can't make medical recommendations. But if you see me in clinic and it's documented for the businessmen and lawyers that I'm your physician, then I can make medical recommendations to your providers and to you too, and that's extremely helpful. So eventually I would love to see everyone here at MGH within, as long as it's possible, both physically, financially, and all of the other stuff, but we would love to try to get everyone here so that I can see you guys. And then finally, I'm going to send out instructions on patient and family videos. Again, this is through the ML4 Foundation, not us yet until we get the IRB approval, but I basically would love to capture the challenges, the strengths and weaknesses of every individual patient. My hope is to use these to make individual endpoints or goals for upcoming clinical trials, but also to illustrate to the FDA, because this is really powerful, being able to show them what kids with ML4 can and can't do, so they have an understanding of what a treatment could possibly affect or improve, and that can make a huge impact. So lots of information to come. Lots of work still going on, but a huge thank you again to everyone who's worked on this, and especially to Rebecca, to Randy, and all of the families. You guys, everything you just saw was made possible by your participation and the tireless fundraising that you've done. we are completely funded on your guys' fundraising efforts. So thank you.
Wow, deep breath and a huge thank you, Albert. Amazing. Okay, so while you will see, Albert, in your messages that I have sent you several times, oh my goodness, you're way over time. And if we were in an individual conference, I would have been holding up the sign saying, uh-oh, we're way over schedule.
Sorry.
I am also going to share with you that so many of the comments in my chat say things like, everything he is saying are things I've never heard before. It's impossible to take in how much this information is needed. Please make sure this is taped and sent out. And versions of that were iterated so many times over that even if I was tempted to shorten everything that you had to say, it was clear to everybody how desperately necessary to the families who are collected here and to all of us your information is. One of the reasons I knew we had to meet virtually, even when we couldn't meet in person, is because I know how much information you have collected. And as you said many times, it's only made possible because every family on this call made it possible. But the thank yous are flowing in now. I can't wait for my daughter to see him. Huge, huge thank you to Dr. Misko and his team. You know, I think people who already have known you and have yet to know you can appreciate that this is a stunningly different level of research than has been done. Whole new levels of understanding of the disease are being made possible here. I just want to offer a quick agenda change. Because of the depth and volume of research that you offered, we lost Dr. Wishart temporarily to another meeting.
Okay.
Because
sorry.
We did run over. He is currently on something else. Dr. Misko is wonderful and easy to listen to. I agree, his information is so useful. We haven't heard this before. Applause all around. So you can understand why I have been praising and touting his work to you on the Facebook group and trying and beseeching all of you to send in your medical records. We will therefore take questions for Dr. Misko now. I just wanted to, as an agenda correction, say that Dr. Wishart, who is again an extraordinarily valuable member of this team, when he becomes available, I am going to jump back to his presentation because you will see that he also brings something very valuable, even if it's in the middle of Dr. Misko's Q&A, and then we'll do their joint Q&A together. So that's kind of what we're doing as a process thing here. I don't know if we still have Sue Slaugenhaupt on the call. She may have had to leave. If she did, we thank her for her incredible participation, and if she's still with us,
I am still here, but I am going to have to jump off. But
correct. So did you want to say anything before you have to leave?
I just wanted to thank Albert, and I in advance thank Brian. Remarkable work, remarkable understand of the disease. I've never heard, in 25 years, I've never heard anyone describe the disease like that. So thank you, Albert. It's just remarkable to see the level of understanding that you've developed of this disease, and we really are so glad to have you involved.
Yeah. Awesome.
Yeah, amazing. And thank you, Sue, for joining us. Nobody really can articulate how busy Sue is and how many areas at Harvard and Massachusetts General Hospital Sue is in charge of. So the fact that she still keeps her significant involvement in mucolipidosis type 4 research is because it is her heart and passion, and really, really cares about each and every one of you. And so I'm supremely, supremely grateful for your time and continued engagement with us. We are where we are because of you. So thank you so much.
Thanks so much.
Okay. So I'd like to now go to some of the questions. If anybody needs to take a break, you know, you're on Zoom, go ahead and take your own breaks. I think we're going to just kind of keep moving along here. I want to, Albert, if you can unshare your screen, that will kind of get back to seeing kind of everyone. Amazing. I want to start with a few sort of basic things. Albert, I know you can answer this question fully. There are several people, more than a few on this call, who had in the past seen Dr. Rafi Schiffman as part of his research study, and had asked me if their data was being included, or have you collaborated with Dr. Schiffman? And of course, I know you have. I guess it's a two-part question. Have you collaborated with Dr. Schiffman? And you can explain that. And then there's the technical question of how those people's data comes to be involved in your project. So we can clarify the technicality of that.
Yeah, Dr. Schiffman and I, we're definitely collaborating 100%. He has been amazingly supportive of my work and the continuation of my work, and we're trying to make it a seamless collaboration where the data will absolutely be used in continuity. So right now, Dr. Schiffman is finishing up his prospective MRI study. We've had one patient come to MGH and get the MRI here, and then we sent the data to him back at Baylor in Texas. But my work is going to be focusing on the neurological aspect of things. So like, how do we assess patients? How do we learn about progression of the disease? Apart from the MRI work that he's also done, but it's definitely in parallel, and they inform on each other. So that's going to be going hand in hand. As his MRI study comes to a close, we're going to try to continue it at MGH and sort of use all of that data together. So Dr. Schiffman's also been wonderful in he has some patient information. So everyone that's been enrolled in the study, I've been able to get files and data from him that he has personally at Baylor. It's been really, really productive, and it's fantastic. But I do think that Dr. Schiffman is going to become more of a mentor role. And then the work will be primarily performed by me under the supervision of him and Florian and everyone else that's involved.
And is it true, Albert, that if somebody was seen by Dr. Schiffman and wants their data included in your study, they just need to let us know and we can make sure that they're included? Right, so if you were seen by Dr. Schiffman and you're concerned to make sure that your information, whatever you were seeing there, you just need to contact me. And I will make sure that we consent you to the IRB, which is the protocol, the signed legal protocol that allows your data to be shared. That's the simple answer to that. Dr. Misko's study is the one that the ML4 Foundation is promoting.
And just so I'm sorry, just one more thing, if that's okay. With seeing Dr. Schiffman, not only is he's wonderful in giving us what he has, but we still need to go back to the NIH and the National Eye Institute to make sure we get the data there, because it's not necessarily completely overlapping, and it's really important that we also have that. And we're having a lot of trouble with the National Eye Institute for reasons that we don't completely understand. But if anyone of the family members can help us go to the National Eye Institute, or contact them rather, and asking for those records, again, it's much harder for them to say no to the families than it is to a research team.
Right. Great. Okay. So one of the issues that you mentioned that I think will help people understand who would be in a clinical trial is the term an endpoint. And I think it would be good if we could talk a little bit more about what that means.
Right, definitely.
I wanted to give you a chance first to just define an endpoint a little bit more clearly, and then explain how an endpoint helps define who might be in a clinical trial.
So an endpoint in a clinical trial is a marker of success of the treatment. So for example, in like spinal muscular atrophy, these kids get treated, and what the endpoint would be perhaps being able to sit unassisted or stand unassisted, something that maybe they would not be expected to do, but with the treatment they were able to do. And if they reach that endpoint, that marker, that is a marker of success. And what the FDA wants to know again is, if you're going to treat these patients, how are you going to know it works? So endpoints can vary over the lifetime of of a patient, right? So maybe the goals, if we treat a 6-month-old or a 1-year-old, are going to be different from the goals of, say, a 15-year-old. And that's what we're trying to understand right now, is in doing this natural history, are what are age-appropriate endpoints for kids with ML4, but also because there are differences in individual patients. What are individual endpoints that we can come up with as well? Like, for this patient at this age, given their level of function, what would be an appropriate endpoint? And again, right now it's a bit nebulous because we're in the middle, we're in, like, you know, the throes of trying to analyze all this data and really come up with strong endpoints. But right now, that is true for all rare neurological diseases across the board. And because of that, the FDA has become much more understanding about sort of fluidity of design, so that they can be more individualized. And you can also move forward saying, you know, this is where these patients are at. I know the natural history this well, even though it might not be perfect. Let's come up with these sort of markers of success for these different age ranges.
That's great. And the thing that I wanted to highlight there is that the quality of life study that Dr. Misko is going to be sharing with you is going to be really super important among everything else in the natural history, because the quality of life study is one of the places where you, parents, are going to be helping us identify what is a meaningful endpoint. There are a lot of trials where a drug company or doctors might think a certain endpoint, helping a child walk, is a great endpoint. And families say, you know what? My child doesn't care about walking. My child cares about this instead, or we as families care about this instead. And so conversations that we will have as a community next about what parents think are really meaningful changes in your child's life are very important. Some other questions that families have. I'm just scrolling through, I'm sorry. You mentioned something about hips being one of the issues that is not negatively affected. And so there was a question. Randy, can you repost your question so I can see it? While we're waiting for that, there's a question about seizures in children with ML4. Some parents have experienced that and some don't.
Yeah, so compared to other lysosomal storage diseases, and ML4 is a lysosomal storage disease, seizures are very infrequent across patients with ML4. But when they have popped up, they're almost all absent seizures, which are staring episodes, and they seem to go away with time, just like in other children. So we have a limited number of patients right now enrolled to know really what the frequency or prevalence is, or if it's higher than in the normal population. But when we have seen seizures, they have been absent seizures, they have responded to medications, and they do seem to go away with age. If anyone has a different experience, I'd love to hear too, by the way.
Sure. If hips were an exception to the muscle tone testing, does this mean that hips maybe had better tone? And is there something that parents should be doing to avoid what has been described by some families as hip problems as kids age, since that has been described?
Yeah, again, I think there's some differences from patient to patient. So if hip tone is high in your child, that can lead to dislocation of the hip. And that's really important because that can be treated with Botox and other things that Dr. Wishart will talk to you about to stop the muscles from pulling on that joint so severely. When I was talking about it in the context of tone, I had noticed that the tone at the hips, just as a generalization, tended to be lower than it was, say, at the ankle or the knee. And I don't know why. I don't know if it's because they're not as affected as much, or perhaps there's more muscle involvement of those proximal muscles, leading to less tightness because the muscles are weaker. And so that's still a question about what's going on. But I would say the one thing you could do now, looking at hip problems, is if that tone is high, that should be addressed by a physical medicine and rehabilitation doctor like Dr. Wishart, because decreasing the tone with Botox locally can stop that hip dislocation from occurring.
Got it. Do you want parents to keep track of these staring episodes that they?
Oh yeah.
Their children? Yes. And how would you recommend they do that?
A log would be great, or a journal or a diary, and things to put in there are basically like what time of day, how long did it happen, and then describe it. And if these are happening periodically, that's actually really meaningful. The other thing you can do, which is really helpful, because sometimes this can be behavioral, is while your child is staring, just give them a little bit of tactile stimulation, give them a touch. Do they respond, or are they still looking straight ahead? You know, behavioral episodes of staring, you can yell at kids and they still won't look at you if they don't want to. But going up to a child and touching them and getting their attention, if they still don't respond, that's a lot more profound than if they won't respond to a verbal cue. So give them a little tap on the shoulder, a little nudge, and see if they respond.
Great. You mentioned before when you were talking about annual assessments, in terms of annual neurologic assessments and so on, in the prospective study. How would you envision that working for people who are outside of the US or have difficulty traveling to see you?
Yeah, so one thing that we're hoping to do is get validation of the caregiver functional assessment so that these things can be done remotely. That is going to take a while to do, and I will have to assess in parallel to prove that skill is actually valid. But I'm not sure, I haven't thought through it completely. Either it's going to be me traveling or trying to bring patients to us, either way. But it's going to have to probably be a combination of those two things. But we don't want to lose anyone, no matter where they are in the world. It doesn't matter to me. We'll find a way.
On the road.
Yes.
Okay.
Yes.
Okay. There's a question about scoliosis. Do you know of situations where a backlift pump can cause this to get worse because maybe of the muscle involvement?
Oh, interesting. I don't know of situations in which it gets worse. Actually, that'd be a good question for Brian too, to see if he's ever heard that. I mean, the intrathecal backlift and pump actually should be relaxing the muscles a little bit. It depends on what's causing your scoliosis, right? So one, it could be caused by muscle rigidity. And so if it's pulling you in a certain direction, the baclofen may be able to relax that, and then the spine wouldn't be pulled in a certain direction. More commonly, it happens because the muscle tone is too low and you're floppy, and because you're not supporting your trunk appropriately, the spine gets kind of out of whack. In that case, baclofen could make it worse if the truncal tone is actually decreasing more and you're slumping more, and that's making the spine become crooked. So I think it's important to, one, identify why the scoliosis is occurring, and then perhaps you can think a little bit more about what's going on. There may be ways to help with that. So one thing that's true about scoliosis and a neurological disorder like ML4, and Brian will talk more about this, is that putting on truncal support is never curative. It never stops it from occurring because the disease is progressive, but it can be a palliative or for comfort measures, basically help you support your trunk. And if baclofen is helping tremendously in the muscle tone in the arms and the legs, so it's doing something great, but it also has the side effect of making the trunk a little floppy and making the scoliosis work, having a brace in combination actually might be appropriate.
Okay. One last question, and then we have Brian ready to go. So one last question, which is, I know a complicated one that I know we are working diligently on at MGH right now, but it's an important question. Does telemedicine provide an opportunity to make you people's physician as opposed to just a researcher?
That's a great question. There has been a huge revolution with the COVID-19 in telemedicine, and we're in the middle of trying to figure out what that means. From a physician standpoint, I've been using it, and I actually really like it. There are big limitations to it that, as a neurologist, most of my assessment is a hands-on physical assessment that I cannot do via telemedicine. The thing that we're waiting on, I think, the most are, again, the businessmen and the lawyers to figure things out, because it's very uncertain what the legal liabilities are if you see someone via telemedicine and then make recommendations when you've never seen them in person, what that means for you. And so as of right now, we're sitting back. If you're someone I've already seen, telemedicine is okay. if there's someone I haven't seen, to have the initial visit be telemedicine, it becomes very uncertain what the implications are. So right now, that's kind of, we're just waiting to see what happens, but it may be a possibility in the future. For right now though, absolutely, if I've seen someone in person, I would love to see them also via telemedicine visits, at any other point as well.
Okay.
To keep up.
Again, I want to thank you very much, Albert. One of the things that I think this lengthy conversation makes clear is that, we may want to do more frequent visits with you, with the ML4 community on discrete topics that people have concerns about, or more frequent follow-ups. I think this lets us realize that we probably don't need to wait every 2 years to catch you.
No, definitely not.
Everyone around the world. So at this point, I think